Good evening, and thank you everyone for joining us today. I, Ankit Dogra, along with my teammates Dr. Deepika Chhabra and Mr. Amit Saxena from Medical Services, Jagsonpal Pharmaceuticals Limited, welcome you all to the PG class today under the able guidance of the new team of AOGD from Maulana Azad Medical College. Today, the case presentations on hypertensive disorders in pregnancy are by the postgraduate medical students of Vardhaman Mahavir Medical College and Safdarjung Hospital, Delhi. The academic partner for today's program is Jagsonpal Pharmaceuticals Limited, the makers of LycoRed Preg sachets of L-arginine, lycopene, and DHA for high-risk pregnancies. Our other brands are Maintane 500 and 250 mg injection of 17 alpha hydroxyprogesterone caproate to maintain pregnancy till the term, and Divatrone 10 mg tablets of micronized dydrogesterone for a safer and smoother journey to the motherhood. Dear attendees, if you have any questions, suggestions, or clarifications, please post them in the Q&A box. Please note this class of PG Forum is streaming live on the Facebook. The link has been shared in the chat box. To refer to this webinar in future, please visit our YouTube channel, Jagsonpal Medical Insights. We express our sincere appreciation to the AOGD office bearers and the coordinators of Delhi PG Forum for taking Jagsonpal Pharmaceuticals Limited as the academic partner for the monthly class of Delhi PG Forum. Now, we request the PG Forum coordinator, Dr. Sunita Malik ma'am, to kindly initiate the program. Over to you, ma'am.
Thank you. Welcome, friends, to this monthly class of the Delhi PG Forum. As already told, it's in hypertensive disorders and pregnancy. Before I start the class, I just wanted to pay condolences to our one worthy member, gynecologist, professor from Maulana Azad Medical College, Dr. Devinder Verma, whom we lost today. I just can't imagine we lost him. He was such a good and fellow gentleman, very knowledgeable and practical person. He was deeply involved in medical education and was pillar of new MBBS curriculum also. May his soul rest in peace, and may God give strength and peace to the family members of Dr. Devinder Verma. Because of that, like today, it was the new AOGD which was supposed to take over, which has taken over, of course, under the guidance of Dr. Asmita Rathore. She's the current president. She is director, professor, and head in Maulana Azad Medical College. Her area of interest is maternal fetal medicine, vaginal surgery. She's also program coordinator of fellowship in maternal fetal medicine. She's got many publications and editor of many books. And of course, professional bodies, office bearer of AOGD, RCOG, expert member of Task Force Maternal Health and National Health Authority. And she was president of NARCHI and now currently president of AOGD. Other members are, of course, Dr. Mala, who's vice president, and Dr. Deepti, who's taken over as secretary of AOGD. And Dr. Niharika is our coordinator from the AOGD for PG Forum. The chairperson for today is Dr. Anjali Jabral. She is head Department of Ops and Gynae, VMMC Hospital. She's been awarded WHO Fellowship in High Risk Pregnancy, and she is faculty for IP University and published many papers in international, national, state journals. She is also life member of AOGD, NARCHI and ISCCP, finance secretary of NARCHI Delhi, and her area of interest are high risk pregnancy and gynae endoscopy. I would like Dr. Anjali to say a few words before starting the class.
Good evening, everyone, and I hope you like this class on hypertensive disorders of pregnancy, and it clears all your doubts. The girls have really prepared hard for this, and without any further ado, this important topic, we will start the discussion.
Thank you, Dr. Anjali. The moderators for today's session are Dr. Sheeba Marwah, Associate Professor from VMMC and Safdarjung Hospital. Her core area is critical care obstetrics, and of course, she is member of Labor Room Quality Care Team in Lakshya also. She is coordinator for local coordinator for the PG Forum from VMMC Safdarjung Hospital also, and she's member of many committees and got many international and national papers published in her name is at such a young age. And of course, she's got Award of Excellence also and other awards also. The other moderator for today is Dr. Nupur Gupta. She is Associate Professor in ESI PGIMSR. Her area of interest is high-risk pregnancy and infertility. So over to Sheeba and Nupur. The residents who are going to present today's classes, Dr. Kajal, Dr. Manasvi, and Dr. Monica. Yes, Nupur and Sheeba, start the class, please, today.
Thank you, ma'am. Thank you, ma'am, for that kind introduction. And Monica, Kajal, and Manasvi, I would request you to please share the slides. Meanwhile, Dr. Nupur wants to add something.
Ma'am, thank you, ma'am. And I would like to thank Dr. Sunita Malik, ma'am, Dr. Shivani, and team AOGD from MC for giving us the opportunity to moderate this session. And now the PGs can start their slides.
Good evening, everyone. Today we are presenting a case on hypertensive disorders in pregnancy. I am Dr. Manasvi.
I am Dr. Monica, and I am Dr. Kajal.
Ma'am, we are presenting a case of Mrs. X, a 32-year-old female, resident of Mubarakpur, Delhi, Hindu by religion, homemaker by occupation, educated till 8th class, belonging to lower middle socioeconomic strata by the modified Kupuswamy scale. She is Gravida 2, Paraval Live 1. Her last menstrual period was on 21st June 2021, and her expected date of delivery was on 28th March 2022. Her chief complaint was that she presented at 7.5 months of period of gestation. She came to our antenatal OPD for routine antenatal checkup where her BP was found to be high. Ma'am, she came to our antenatal OPD at 7.5 months of amenorrhea. Her BP was taken, and according to the patient, as told by the doctor, the BP was high and she was advised admission for further management. There was no history of headache, blurring of vision, chest pain, decreased urine output, swelling of feet, or excessive weight gain. No history of pain abdomen, leaking per vaginum, or bleeding per vaginum. It was a spontaneous conception by a non-consanguineous marriage. She diagnosed her pregnancy at 1.5 months of period of gestation by a urine pregnancy test done at home. She was booked at Safdarjung Hospital at 2 months of period of gestation. During her booking only, she was advised antenatal investigations and first ultrasound was done, which were normal according to the patient. She was advised to take 1 yellow color tablet every day, which she was taking regularly. There was no history of nausea, vomiting, blurring of vision, or any history of fever with rash, any history of radiation or drug exposure. Quickening was felt at 5 months of period of gestation. She was perceiving adequate fetal movement since then. She has received 2 doses of tetanus toxoid at 4th and 5th month of period of gestation. In the second trimester, she had undergone ultrasound at 5th month of POG, which was normal according to the patient, and she underwent some lab investigations as well, which were normal. There is history of regular intake of a red colored, yellow colored and a white colored tablet every day. White colored tablet was taken was started after 3 months of period of gestation, and there is history of intake of another white colored tablet which she was taking twice a day. No history suggestive of impending eclampsia or gestational diabetes or anemia. On her third visit in the third trimester, at 7.5 months of amenorrhea, her BP was done, which came to be high as told by the doctor, and she was advised admission for further management. Menstrual history, her age of menarche is 12 years. The past cycles are normal and the flow is normal. The past cycles are regular. Obstetric history, she has been married twice. The second marriage is a non-consanguineous one. Her first baby is from the first marriage, a boy baby, full-term vaginal delivery, birth weight of 2.4 kg. There was history of high BP records near term in this pregnancy, and she was treated with antihypertensive drugs. The intrapartum and the postpartum period was normal. There was no significant medical or surgical history. There is history of hypertension in mother, which was diagnosed 10 years back, and it is controlled on oral medications. Personal history, she has adequate sleep with normal bowel and bladder habits. No history of addiction are there, including alcohol and smoking. Dietary history, she takes a mixed diet. By a 24-hour recall method, she consumes 25 kilocalorie per day and 62 grams protein per day, which are normal according to her lifestyle.
Yeah, so Manasvi, what do you think this case is till now, as of now?
Ma'am, my provisional diagnosis by history is that she is a 32-year-old lady, Gravida 2, Para 1, Live 1, at 32 weeks and 5 days of period of gestation with hypertensive disorder of pregnancy.
So why do you think it's hypertension? You've just taken the history. So what are the pointers? Yeah.
Yes, ma'am. There are many pointers in my history. First, ma'am, when she came to our antenatal OPD, her BP was high. There is history of hypertension in her previous pregnancy as well. And there is history of family history of hypertension in her mother. Also, her inter-pregnancy interval is more than 10 years.
So these are the risk factors which predispose her to having hypertension, and further you will go for the examination. So when do you say it is a hypertensive disorder in pregnancy?
Ma'am, hypertensive disorder in pregnancy is defined as when any pregnant female with a systolic blood pressure of more than or equal to 140 millimeters of mercury and a diastolic blood pressure of more than or equal to 90 millimeters of mercury when taken on 2 occasions 4 hours apart.
How do you classify it?
Ma'am, hypertensive disorders of pregnancy are classified based on the period of gestation. When a patient comes with a high BP that is more than or equal to 140 by 90, we will ask the period of gestation of the mother. If the period of gestation is less than 20 weeks, then we will categorize her as chronic hypertension. With high BP, evidence of new onset proteinuria or worsening proteinuria is there, then we will categorize her as chronic hypertension with superimposed pre-eclampsia. If her period of gestation is more than 20 weeks and there is no evidence of proteinuria, she will be categorized as gestational hypertension. And if there is evidence of proteinuria or end organ damage with or without proteinuria, she will be categorized as pre-eclampsia. If gestational hypertension and pre-eclampsia, if the BP does not settle even after 12 weeks postpartum, then the patient will be categorized as chronic hypertension.
Okay, so go ahead with the examination. Okay, before that, you have already told us what are the risk factors. So can you tell again what are the risk factors? Enumerate the risk factors in history which you are getting.
Yes, ma'am. Ma'am, according to the NICE 2019 guidelines, in our patient, there is one major risk factor that is present. That is, there is history of hypertension in previous pregnancy. There is a moderate risk factor also, that the inter-pregnancy interval is more than 10 years. So there is one major risk factor and there is one moderate risk factor. According to the ACOG 2019 guideline, there is history of preeclampsia in previous pregnancy, and also the inter-pregnancy interval is more than 10 years in this patient.
Okay, so you are talking about the American and the UK studies. So we have an Indian score also, no? What is that?
Yes, ma'am. Yes, ma'am. It has been recently devised. The score is called the Hypertensive Disorder of Pregnancy Gestosis Score, where there are 27 points, and they are divided into mild risk factors, moderate, and severe risk factors. The mild risk factors are given a point of 1. The moderate risk factors are given a score of 2, and severe risk factors are given a score of 3. If the total score of the patient is more than or equal to 3, we will start her on we will categorize the patient as high risk, and we will start her on low dose aspirin 75 to 150 milligram at 12 weeks of gestation.
So very important is that the scoring is done only once you do the examination also, and you measure her blood pressure as well. But most important thing is that it also takes into account the mental status of the patients also. So you've not taken that point in the history, right? So, okay, go ahead with the examination. Monica?
Starting with the examination, the general physical examination, patient was comfortably sitting, conscious, cooperative, well-oriented to time, place, and person, averagely built and well-nourished, general condition being fair, height being 152 centimeter, pre-pregnancy weight 50 kg, her BMI calculated was 22.2 kg per meter square, which is normal. Her current weight is 59 kgs. Hydration of the patient was adequate. Patient was afebrile to touch. Pulse rate 84 per minute in right radial artery, regular with good volume, normal character, and no radial or radiofemoral delay. All peripheral pulses were palpable. On recording the blood pressure reading was found to be 146 by 92 millimeter of mercury in the right arm in sitting position, repeated after 20 minutes, which is found to be 142 by 90 millimeters of mercury. Respiratory rate was...
So you said that blood pressure was 146/92 in the right arm in sitting position. So what are the positions in which you have to take blood pressure in an antenatal woman, and any other things which have to be taken into mind?
Whenever a patient is received in the OPD, the patient is given adequate rest of at least 10 to 15 minutes, after which the blood pressure has to be recorded. Clinical sphygmomanometer is used for the measurement of the blood pressure. The blood pressure cuff is tied 2 centimeter above the cubital fossa in the right arm, most common position being the sitting position. Adequate size of the cuff should be taken into mind while measuring the blood pressure, which involves the cuff size to be 1.5 times more than the arm circumference, or the bladder in the cuff should cover at least 80% of the hand circumference of the arm. Different position in which the blood pressure can be measured are sitting position, semi-recumbent position, left lateral position.
Yeah, so but these days we don't use the sphygmomanometer, Valana. We use
other instruments that can be used. Automated blood pressure machine can be used for the measurement of blood pressure, but it should be calibrated with a clinical sphygmomanometer.
Correct. Okay, so go ahead with the examination.
On head-to-toe examination, there was normal hair texture, orodental hygiene was well maintained, there was no pallor, icterus, cyanosis or clubbing, but grade 2 pedal edema was observed, no palpable lymphadenopathy or thyroid enlargement was seen, and bilateral breast showed normal changes of pregnancy.
So any significance of pedal edema in hypertensive disorder? Or any change?
Previously, presence of pedal edema was taken into consideration for a diagnosis of pre-eclampsia, but recently it is removed for diagnosis of pre-eclampsia because of presence of physiological pedal edema as well. If the pedal edema is present and there is recent worsening of pedal edema or sudden gain of the weight in the patient or progression of the edema towards the body, then it is to be taken into consideration for pre-eclampsia.
So for the benefit of all other postgraduates who are also attending this, how do you grade pedal edema?
Pedal edema can be graded. Grade 1 is limited to the ankles. Grade 2 is below the knee. Grade 3 is above the knee. And grade 4 is generalized edema.
This is generalized anasaka. Okay, go ahead with the examination. Yeah.
Systemic examination, respiratory system, no significant abnormality noted. Cardiovascular system was normal, no significant abnormality. CNS, no sensory or motor deficits, all reflexes were normal. On abdominal examination, inspecting the patient, the abdomen was uniformly distended, the uterine ovoid well maintained in longitudinal axis, all quadrants moving well with respiration. Umbilicus was central and inverted. Linea nigra and striac gravidarum was seen. No dilated veins or any scar marks present. All hernia sites sites were free on cuff impulses. On palpation, the inspectory findings were confirmed. The local temperature was not raised. Symphysis fundal height measure was 30 centimeter and abdominal girth measure was 92 centimeters. Uterus was corresponding to 30 weeks size. Fetus was in cephalic presentation, uterus being relaxed and non-tender. Clinically, the LycoRed appeared to be adequate and the effective fetal weight was around 2 kg. On auscultation, fetal heart sound on right spino-umbilical line, which was regular in rhythm with 135 beats per minute rate. Per speculum and per vaginal examination was not done. Urine albumin was done by dipstick test, which was found to be +2.
So why did you do a urine albumin test in this patient? What do you mean by a significant proteinuria?
Significant proteinuria is excretion of more than equal to 300 milligram of protein in 24 hours of urine. Significant proteinuria, the main aim of our doing the dipstick test was to identify the proteinuria and how much amount of protein excretion is there. Different methods used for measurement of proteinuria are 24-hour urinary sample for the measurement of protein. More than 300 milligram per 24-hour urine is indicative of significant proteinuria. Another specific method, that is spot protein creatinine ratio. The ratio of more than equal to 0.3 milligram per DL, or if it is not available, then albumin to creatinine ratio of 8 nanogram per ml is significant proteinuria. In the absence of these quantitative tests, the bedside test that can be done is the dipstick test. The reading of +2 is taken into consideration for a significant proteinuria.
So the 24-hour urine protein is not now done usually, and we do a spot protein creatinine ratio, which is the ideal test for this. And the dipstick reading you said, which is a bedside test for documenting proteinuria and differentiating between pre-eclampsia from hypertension. So why are you taking a reading of 2+ as important and not 1+? Earlier
According
you
to
used
the
1+.
According to the ACOG 2019 guidelines, it has been found that researchers show that +1 dipstick urine albumin shows 71% of false positive values, whereas +2 shows relatively accurate values and only 3% of false positive values are found. So
Yeah.
accuracy for identifying a significant proteinuria is by 2+ reading considered for dipstick test.
Correct. So what are your final diagnosis after your history and examination?
Dr.
is the
based on
just a minute, what type of proteinuria do we see in the patients of pre-eclampsia? Is it selective or it is non-selective type of proteinuria?
In pre-eclampsia, there is a non-selective proteinuria because there is generally leaking of the capillaries, due to which the protein gets accumulated into the interstitial spaces. So the proteinuria in pre-eclampsia is non-selective.
Now you can continue.
So what is the final diagnosis after history examination?
My final diagnosis is a 32-year-old lady, gravida to paravan like 1 at 32 + 5 weeks periods of gestation with singleton live fetus in longitudinal lie, cephalic presentation with pre-eclampsia without severe features, not in labor.
So why do you say it's pre-eclampsia without severe features? How do you classify or differentiate between pre-eclampsia with severe features and without severe features?
Pre-eclampsia is defined as a systolic blood pressure of 140 or 140 to 159 mmHg, or diastolic blood pressure of 90 to 109 millimeter of mercury with significant proteinuria and no target organ damage can be labeled as pre-eclampsia without severe features. But if the patient is having systolic blood pressure of more than equal to 160 millimeters of mercury, or diastolic blood pressure of more than equal to 110 millimeters of mercury, proteinuria may or may not be present, but there is presence of target organ damage, it is labeled as pre-eclampsia with severe features.
So how do you assess this target organ damage in a patient of pre-eclampsia with severe features? What will be shown? Yeah.
The points to be noted while labeling a patient with pre-eclampsia with severe feature is high BP record of systolic blood pressure more than 160 and diastolic blood pressure more than 110 millimeters of mercury on 2 occasions 4 hours apart, with target organ damage including thrombocytopenia less than 1 lakh platelet, impaired liver functions where there is elevated blood concentrations of the liver enzymes SGOT and SGPT, aspartate and alanine aminotransferase, more than touching the double the upper limit renal insufficiency where the serum creatinine concentration is more than 1.1 milligram, or there is doubling of the serum concentration from the previous report. There is onset of pulmonary edema, new onset of headache that will be unresponsive to any medications and not controlled by any, counted by any alternate diagnosis, and there are presence of visual disturbances.
Okay, and what are the visual disturbances?
The patient may experience blurring of vision, there may be flashing of light, there may be photophobia, scotoma.
And what else? And what else visual disturbances can you see besides you enumerated?
Patient may also have sudden onset, sudden loss of the vision.
And it is normally temporary loss of vision in most of the patients. It is temporary. And what are the causes for temporary loss of vision in a patient?
Due to the edema in the posterior region of the brain or retinal detachment. These two are the causes of reversal.
And what is Prashna's retinopathy?
Prashna's retinopathy is vasogenic edema in the parietal.
That is vasogenic edema in the occipital lobe. It is called as amuresis. And Prashna's retinopathy is when there is retinal
when it is due to retinal detachment.
No, that is amuresis lax, which you were telling. Yeah.
And what is the cause for permanent vision loss in a patient of pre-eclampsia? Though it is very rare, but what is the cause for permanent loss of vision?
Permanent loss.
Yeah.
Yeah.
Okay, it may be due to if there is a retinal artery occlusion, then it can lead to permanent loss of vision. Otherwise, mostly in pre-eclampsia, there is only temporary loss of vision with regain of vision 1 to 2 weeks postpartum. Now you can continue.
So, Monica, how would you proceed to manage this patient?
Yes,
this patient, she's 32+5 and she's pre-eclampsia without severe features.
Ma'am, we will admit the patient for safe confinement and maternal and fetal surveillance will be done.
So how do you assess maternal assessment? Yeah.
Ma'am, maternal assessment, BP monitoring will be done every 4 to 6 hourly, not done at the time from 12 a.m. to 6 a.m. 12 p.m. to 12 a.m. to 6 a.m. in the night. So then examination including measurement of body weight on the admission. We will watch for signs and symptoms of impending eclampsia, that is headache, visual changes, nausea, vomiting, epigastric pain. We will watch for signs of labor, that is presence of contractions, rupture of membrane, abdominal pain, bleeding, and we will do the lab tests which include complete blood count with platelet count, liver function test, kidney function test, urinary protein estimation, and coagulation study only when indicated, fundus examination.
Arjun, just a minute. Already you had said that your patient had 2+ proteinuria. So would you like to repeat your protein estimation again?
No, ma'am. Urinary protein estimation is done only at the time of admission. Once we have,
you don't need to repeat it.
Yes, ma'am.
It is done to diagnose for a case of pre-eclampsia. It is not done for any, either it is not an indication for termination or for severity, nothing. Only we have to do at the initial visit when we are diagnosing a patient to be labeled as pre-eclampsia.
It's only for the diagnosis. It's done once, and once you have diagnosed, then you don't need to repeat it. CBC with platelet count, LFT, KFT, how often do you repeat them?
Ma'am, we will repeat twice per week in this case.
Okay. And you said coagulation study only when indicated. So what are the indications of coagulation studies?
Ma'am, coagulation study is done if there is thrombocytopenia, deranged liver function test, or some bleeding is there, or we are suspecting abruption or HELLP syndrome.
Okay. And you said fundus examination. So what characteristically you're looking in fundus examination?
Ma'am, in fundus examination, we will look for the changes in the retina. According to Keith Wigner classification, there are 4 grades of hypertensive retinopathy. In grade 1, only mild arteriolar attenuation is there. Till grade 4, in which there is silver wiring and disc swelling. So grade 4 is the indication for the termination of pregnancy.
Okay. And how do you assess the fetus? You told us about the mother. How would you assess the fetus in this patient?
Ma'am, fetal assessment, we will ask the patient to perform daily fetal movement count, which is more than 10 counts in 12 hours or more than 3 counts post meals in 1 hour. NST will be done at the time of admission and twice weekly. Serial fetal growth monitoring as guided by the clinical examination. Modified biophysical profile will be done every week, and umbilical artery Doppler to be done at the admission. And if we suspect FGR, then every 2 weeks.
Okay. So what were the investigations of this patient? Yeah, let's go ahead with this.
Ma'am, investigations on the admission, CBC, hematocrit, peripheral smear, KFT, serum electrolyte, and fundus examination was within normal limit. LFT was slightly deranged.
Okay. And did you do the ultrasound also of this patient?
Yes, ma'am. Ultrasound was done at the time of admission, which was normal and corresponding to the period of gestation, and Doppler studies were also normal.
And what is the indication of Doppler in this patient? Do you have to do Doppler every time?
Ma'am, Doppler is indicated because Pre-Eclampsia is high risk for fetal growth restriction. So to rule out early growth restriction, we have to do Doppler studies.
Any evidence for this? Any trial you know of? No. Okay. So you said now any test which you could do that would predict whether this patient who is a pre-eclampsia without severe features would go and worsen to become a patient with pre-eclampsia with severe features.
Yes, ma'am. Yes,
So what is that?
we can determine the ratio of SFLT raised to placental growth factor ratio to determine whether the patient can develop into severe pre-eclampsia. It has rule in and rule out criteria. Rule in criteria include if it is less than 38, then we can rule out that the patient will not develop pre-eclampsia for 1 week. And if it is in early less than 34 weeks, it is the value is 85. And if it more than 34 weeks, then the value is 110, which will rule in that the patient can develop pre-eclampsia within 4 weeks.
So within next 4 weeks, so she can always have pre-eclampsia. Okay. Yes. So further, what was the course of the patient? You did the
just a minute. So can you suggest any clinical model which can predict worse maternal outcome in a patient of such a pre-eclampsia which you have admitted? Any clinical model you know? Have you heard of full pyres and mini pyre?
Yes,
full pyres and mini
pyre and full pyre. Yeah.
What are these models? What is full pyre model? Actually, these models, they are just to predict the worst maternal outcome, and in full pyre it is mostly done in developed countries and in medical college level where the lab investigations are available 24 hours. The various features which we look into are the gestational age, the symptom of chest pain or dyspnea, pulse oximetry, and the three lab features which include aspartate aminotransferase, creatinine, and platelet count. So the aim is to identify the patients, high-risk patients who are going to develop worse maternal outcome so that we can timely intervene and we can strictly monitor these patients. And in mini-pyre, it is for developing countries and for district level hospitals where 24 hours lab investigations are not available. In this, mostly there are signs and symptoms like abdominal pain, vaginal bleeding, parity, gestational age, plus only dipstick urine and BP is measured. And the aim for mini pyre is so that we can timely refer the patient to higher center and timely intervene and prevent further complications such as severe pre-eclampsia with severe features and other features. Okay, now you can continue.
Yeah, so pyre is calculator and we preempt the development of adverse outcome.
It is only for maternal outcome. It has nothing to do with fetal outcome.
So what was the further course of the patient?
Her BP recordings were persistently more than 140/90. So she was started on tablet labetalol 100 mg twice daily. BP monitoring was done every 4 to 6 hours. Fetal monitoring was done. There was gradual increment in the dose of tablet labetalol to 200 mg 3 times a day. She had been perceiving adequate fetal movements. There were no signs and symptoms of impending eclampsia. Patient was discharged in satisfactory condition once her BP was controlled and initial evaluation was done. After 5 days, patient was discharged on the advice and follow-up after ensuring her compliance.
So what advice did you give, or did you ask her to follow? Yeah.
What, ma'am?
Acha,
Anjali ma'am, please.
I said, why did you increase the dose?
Ma'am, BP was not controlled. The BP chartings were in between. Some BP readings were high, so we increased the dose to 200 milligram 3 times a day.
So
Ma'am,
what is
our
the
aim-
indication of what
So
is the
how
indication
much,
of starting?
what?
Yes, ma'am. Ma'am, please
What?
go ahead.
Nothing. I said, what were you aiming at till how much
Ma'am,
BP were
we
you?
were, ma'am, our aim was to keep the BP less than 135/85 according to the NICE guidelines.
You start by 140/90 in the antenatal period. And what is your target?
Our target is 135/85.
But there are different targets by the ACOG and by the NICE guidelines.
Yes, ma'am.
So what is that? So
Um,
when do you start the antihypertensive therapy and what are the options? This you said na labetalol 100 milligram twice a day you started.
Yes, ma'am.
Yeah.
Ma'am, we will offer pharmacological treatment if BP remains above 140/90 millimeters of mercury. Our aim of the BP is 135/85 millimeters of mercury or less. Labetalol is the antihypertensive treatment of choice. ACE inhibitors and ARBs are contraindicated, and we can consider nifedipine and methyl dopa as second-line drugs. The labetalol is the drug of choice. Its mechanism of action is beta blocker with mild alpha vasodilatory action. Initial dose is 100 milligram twice daily. Maximum dose which can be given is 2400 milligram. It is contraindicated in asthma, COPD, CHF, heart block, and bradycardia. So other drugs.
As ma'am, yeah. So as ma'am asked you that what was the target? So you know of any trial which was done to set the target of blood pressure?
Yes, ma'am. CHIPS trial was there, which is control of hypertension in pregnancy, which told us about the stricter control, which was stricter control of blood pressure in the pregnancy.
So what happens when you have a stricter control of systolic blood pressure and diastolic blood pressure?
Ma'am,
You have
there
a
will be less
control.
chances of patient developing severe hypertension during pregnancy, and there will be no fetal harm if we have stricter control.
So are you worried about the maternal outcome or the fetal outcome again?
Ma'am, for maternal outcome, we are doing stricter control. There is no effect on the fetus.
Okay.
Okay,
So-
when do you decrease the dose and when do you increase the dose?
Yeah, how did you titrate?
Ma'am, if BP is coming persistently less than 110/70, so we will stop the antihypertensives. If it is coming in the range of 1 till 140/90, we will not increase the dose. But if it is persistently coming high more than 150/100, so we can increase the dose and titrate according to the BP chartings.
Okay. So you discharge the patient.
Ideally, you
and did
should
you...
not go beneath.
Yeah. Right. So Monica, you discharged the patient and you gave her some advice. So anything had to be done on her end apart from taking labetalol at home?
Yes, ma'am, she should monitor her BP at least twice daily. We have explained her the signs and symptoms of impending eclampsia when she should immediately visit the emergency services. And we have advised her to regularly follow up in the antenatal OPD every week with investigations.
So what happened next?
Dr. Kajal, what is the time limit when the patient with pre-eclampsia with non-severe features can progress to pre-eclampsia with severe features? It is a very rapid progression. It can occur within days. Therefore, the monitoring is very, very essential. We have to always tell her about the warning signs, and we have to tell her to come to the OPD for her lab investigations. Okay.
Yes, ma'am.
Yeah, so you have to increase the frequency of a follow-up and to ask her for being compliant with the antihypertensives and the BP charting at home. And at any time she has any warning symptoms, which you must have explained at the time of discharge, she should report to the gynae casualty immediately. So what happened next? You discharged her and she was compliant. And she
Sheeba?
was coming. Yes, ma'am.
Can you ask them, will you continue with the same drug till the full dose or will you add a different one in between?
Yeah.
Yeah.
So what is you said na, there are 3 drugs. You
Yes,
said
ma'am.
the labetalol is the first choice. So what happens if you start, what is the maximum dose of labetalol, oral labetalol, which you give? And
Ma'am,
yeah.
Maximum dose which can be given is 2400 milligram, but in Safdarjung hospital we give only till 800 milligram. Then we add tablet nifedipine 10 milligram per oral because
yeah, so once we once a patient is taking 200 milligram QID and the blood pressure is still not controlled, then we switch over to the other class of antihypertensives along with it, and not only go on giving the same drug again and again, and then we add nifedipine. So, but the caution is that it should not be taken. Nifedipine should not be taken sublingually. It has to be given per oral tablet. Yeah. Okay. So you discharged the patient and you were asking her to follow up in OPD. Then what happened? Further course?
Ma'am, on her second follow-up in the OPD after 2 weeks at 35 weeks and 5 days of period of gestation, her BP was in the range of 150, 100 and 146, 92 on tab labetalol 200 milligram 3 times a day. So she was again admitted and labetalol dose was increased to 4 times per day. Then despite this, BP was not controlled. So tablet nifedipine sustained release 10 milligram per oral was added. But once again, she developed BP reading, 2 BP readings more than 160, 110, or even on the combined antihypertensives. So we have given her injection labetalol, 20 milligram IV stat, loading dose of injection magnesium sulfate, and decision taken for termination of pregnancy.
So she now became severe pre-eclampsia. And
Yes,
how do you manage this patient now?
Kajal, just a
Why
minute.
did you give a Maxal? Why did you give a Maxal?
Yeah, severe preeclampsia. Why did you give Maxal?
Ma'am, Maxal is given for seizure prophylaxis to prevent the patient to
Develop impending eclampsia.
And what is the evidence? What is the evidence of giving Maxal in a patient of severe preeclampsia?
The MACP trial was done in which magnesium prophylaxis and impending eclampsia, in which half the population was given placebo and half the population was given magnesium sulfate in the patients with gestational hypertension or preeclampsia without severe features. Results show that the population who were given placebo, 2.2% of the population developed eclampsia, whereas from the population who were given Maxal, 1.1% of these patients ended up in eclampsia.
Okay.
So severe pre-eclampsia, the risk of seizures is 4 times lesser if we give Maxal.
Yes,
decreases. So how do you manage her severe hypertension?
Yes, question, please.
Yes. Yes.
What is the effect of oral labetalol on fetus? What is the side effect of oral labetalol on fetus?
Ma'am, it can cause hypoglycemia in the fetus, or it can decrease the beat-to-beat variability.
No, that to Maxal causes. Labetalol, it causes intrauterine growth restriction in the fetus. Plus, it can also lead to fetal bradycardia. Okay, now you proceed.
But it causes less IUGR than the others.
It is less, but it can cause.
It's one of the side effects, but since it is relatively very negligible, so it is preferred drug.
It is preferred, but students should know that already with the preeclampsia there are chances of intrauterine growth restriction. So we should always be aware of the side effect.
Correct.
But it has very minimal effects. That's why it's chosen.
Yes.
So how do you manage this patient now?
Ma'am, severe preeclampsia, we go for a four-pronged approach for severe preeclampsia. In our patient, the BP was more than 160 by 110. So first, we will control the blood pressure by giving her antihypertensives. Second, because we have to prevent seizures in future, therefore we will give her seizure prophylaxis. Corticosteroid cover is given in patients who are less than 34 weeks of period of gestation, and we will also plan for termination of pregnancy. In our case, because the period of gestation was just 35 weeks plus 2 days, that is why steroid cover was not given. But
she had passed that period. Yeah, so she had passed that period. She had already had the lung maturity. And yes, so we are not going to give her the corticosteroid cover. So seizure prophylaxis and antihypertensive. So how do you give the antihypertensives to manage this severe hypertension in such patients?
Ma'am, the first line treatment for severe preeclampsia is intravenous labetalol. when we get a patient whose BP is more than or equal to 160 by 110, we will repeat the BP after 15 minutes. We are not going to repeat the BP after 4 hours in this case, because we have to institute the treatment as soon as possible and preferably within 60 minutes. That is why we are repeating the BP within 15 minutes. We are going to give her injection intravenous labetalol. This is the algorithm as advised by the ACOG 2020 Safe Motherhood Initiative, where if the BP is more than 160 by 110, we give injectable labetalol 20 milligram over 2 minutes, and then we will repeat the BP after 10 minutes. The action of labetalol comes within 2 to 3 minutes, and we will repeat the BP after 10 minutes. And if the BP is more than threshold, we will give again dose of injection labetalol 40 milligram, and we'll repeat the BP after 10 minutes. A maximum dose of 220 milligram is given in our institution, although guidelines say that maximum dose of 300 milligram can also be given.
We don't give 220 milligram. We give we give a 20 ka shot, then 40, and then 80. And if it is not controlled as per the departmental SOPs, we then switch over to the other drug. So that is nifedipine or the NTG, right?
Yes, ma'am.
So,
yes, ma'am.
So otherwise, the maximum recommended is 300 milligram. That is 20, 40, 80, and 80 and 80. But we,
Yes,
after 20, 40, and 80, we go over to the other antihypertensives. Okay. So what are the other antihypertensives available?
Ma'am, if the BP is not controlled on injectable labetalol, we will seek for medical specialist advice. We will admit the patient in high dependency unit, and we will start the patient on nitroglycerin. Ma'am, a dose of 5 microgram per minute is given, and dose is increased by 5 microgram per minute every 5 minutes. A maximum dose of 20 microgram per minute can be given. Ma'am, nitroglycerin acts by venodilation as well as arteriolar dilation, so it decreases the preload as well as the afterload. So it is the antihypertensive of choice in patients who come to us with pulmonary edema.
Okay. And what other drugs? Any other drug which you can give apart from labetalol and this?
Ma'am, yes, ma'am. Ma'am, if the patient, we cannot secure an IV access for the patient, an oral drug, that is immediate release tablet nifedipine, can also be given, which is given at a dose of 10 milligram. We will repeat the BP after 20 minutes. And if the BP threshold is high, then is not achieved, then we will give another dose of 20 milligram oral nifedipine. Even after, even after 2 doses of nifedipine, the BP is not controlled, we are going to secure an IV line, and we will start her on, we will give her injection labetalol 20 milligrams.
So that is very important. When we switch over from nifedipine to labetalol, then how often do you repeat labetalol?
Ma'am, we have to give 2 doses of labetalol of 20 milligram dose each. And
always it has to be a multidisciplinary approach where a maternal fetal medicine specialist, an internal medicine specialist, and anesthesia and critical care specialist should be in charge. Right. Yes, so, okay. So, you've done this. Then the 4th prong was planning the termination of pregnancy. So how you formulate the plan of induction for this patient? She's 35 plus 5 weeks, severe preeclampsia, G2P1L1, previous vaginal delivery.
Planning for termination of pregnancy, but before that we will give her seizure prophylaxis.
Yeah, Kajal, can you tell us about how will you give seizure prophylaxis? How do you give Maxim? What is the
drug of choice for seizure prophylaxis is magnesium sulfate. Yeah. This is the MACP trial as mentioned before that claims that magnesium sulfate given during labor and for at least 24-hour postpartum will reduce the risk of seizure in women with severe pre-eclampsia or imminent eclampsia.
By at least 4 times, yeah?
Yes, okay. Yes, ma'am.
So what is the mechanism?
The mechanism of action is it reduces the presynaptic release of neurotransmitter glutamate, which is a stimulatory neurotransmitter. It causes blockage of the glutaminergic N-methyl D-aspartate receptors at the neuromuscular junction. It potentiates release of adenosine as well as it causes blockage of calcium entry via voltage-gated calcium channels.
Correct. So how do you give it? How do you institute? Yeah.
The most commonly used and standard regimen is the Pritchard regimen that we use in our setup also. A loading dose is given. 4 gram of 20% solution is given slow intravenously over 5 minutes, followed by 10 gram of 50% solution. 5 gram in each buttocks is given deep intramuscularly in the upper outer quadrant.
Kajal, how do you make this 20% solution?
A vial of magnesium sulfate contains 10 ml of solution. In every 2 ml, there is 1 gram of magnesium sulfate. So 8 ml of magnesium sulfate is dissolved with 12 ml of normal saline, which constitutes a 4 gram solution of 20% magnesium sulfate. This is given slow intravenous.
Yeah. So usually we get the vial that is 10 ml vial by 50% weight by volume. Otherwise, you also get a 2 ml vial. Okay, by 50% weight by volume, which is 1 gram.
1 gram.
So you draw 4 grams, 8 grams, and you 8 ml, 4 grams, and you dissolve it in 12 ml normal.
12 ml normal saline.
Okay, and you have to give it deep intramuscular. And if the patient has pains, to prevent that, what
we
do you
can add 2% lignocaine. It will minimize the discomfort to the patient and reduce the pain.
Okay, and so how is the maintenance dose given?
Maintenance dose is given every 4 hourly. 5 gram 50% solution is given deep intramuscularly in upper outer quadrant of alternate buttocks every 4 hourly.
Okay. Any other regime if the patient is too critically ill and she cannot take in a scenario where she cannot take this intramuscular injections? You think she might
intravenous regimen, that is the Zuspan regimen, where the patient is given 4 gram of 20% solution, slow IV over 5 minutes, and the maintenance dose is 1 gram per hour. 50% solution is given.
Okay, and you know of any low dose regimes of
other low dose regimens that are used are Sibai and Dhaka regimen. The main aim of this regimen was the Asian women are of low weight compared to that of the Western countries. So these low dose regimens were made based on the weight of this patient.
Yeah, we have a very pertinent comment by an esteemed faculty. Ma'am says that we must emphasize that the mechanism of action of Maxelf is to relieve the cerebral vasospasm. So by all the methods you told it acts, the ultimate aim is to decrease the cerebral vasospasm so that seizure is prevented. So that is the main thing. So okay, so you give Pritchard regime, you started patient on Maxelf, and how do you monitor such patients?
First dose of magnesium sulfate does not require Foley's catheterization, but successively Foley's catheterization should be done, and hourly monitoring of urinary output should be done. Deep tendon reflexes should be monitored, and respiratory rate should be monitored. It should be continued.
How much should be the urinary output?
It should be more than 30 ml per hour.
And the DTR should be present, and what is the
respiratory rate should be more than 14.
12
to 14.
Yeah, 12. So, okay. So we continue with Maxelf. We keep on monitoring. Now, suppose this patient, you have put her on Maxelf, and meanwhile you are doing simultaneously, you formulated a plan for induction as well, and you're controlling her hypertension, and suddenly her urine output decreases, or the deep tendon reflexes is gone. Then what do you do?
Whenever any sign of magnesium toxicity is observed, serum magnesium levels are to be sent to see the serum levels, whether they are within the therapeutic range or they are within the toxic ranges.
So we do not recommend routine magnesium level measurements, no?
Yes, ma'am. Whenever any toxicity is suspected, before giving next dose, we should be having idea about the serum magnesium level so that we can prevent the toxicities.
But what happens if a urine output is decreased? If it is less than 30 ml per hour, after you assess on Pritchard regime, 4 hours ke baad aap assess kar rahe ho. So what happens to, what do you do for the next dose? Do you omit Maxelf?
No, the next dose cannot be, we can reduce the dose half to 2.5 gram, and it can be given to the patient, and monitoring of the other symptoms, that is the deep tendon reflex, respiratory rate should also be done. Meanwhile, we should obtain the serum magnesium levels.
Okay. And when you think that the magnesium levels have crossed the toxic range and the patient has magnesium toxicity and has respiratory distress or respiratory distress, then what do you do?
Urgent if the patient has respiratory paralysis, urgent intubation should be done, and airways should be secured, and patient should be given the antidote, that is calcium gluconate. Calcium gluconate, 1 gram of calcium gluconate, that is 10 ml of 10% calcium gluconate should be given intravenously slowly over 10 minutes. And we should withhold the next doses of magnesium sulfate.
And any other considerations during labor of this patient which you need to monitor? We'll come over for this. So you've told us about the Maxel. So can we now come to the termination plan and the labor considerations?
Yes, ma'am. Termination of pregnancy. The decision for normal vaginal delivery versus cesarean section depends on number of factors, that is maternal and fetal condition, parity, past delivery history, gestational age, cervical status, and presentation. In our case,
tailored to this patient, you will give her a trial of labor.
We will give a trial of labor, and we have done induction of labor.
Okay. So what are the methods available?
Ma'am, we can use prostaglandins for the cervical ripening, or we can do amniotomy. If the Bishop's is good, we can do augmentation with oxytocin.
So the aim is that you need to finish the induction, and termination should not be prolonged because she is preeclampsia with severe features and she can anytime deteriorate. So the induction should not go beyond 24 hours, right? So
Yes,
what will be the intrapartum management points? Just important points which you should take care of.
Yes, ma'am. We will do hourly BP monitoring. We will continue the use of antenatal antihypertensives during labor, continuous electronic fetal monitoring in active labor, and do not overload the patient with IV fluids.
So what is the rider for the IV fluids? How much the fluid should be there?
Ma'am, we should limit the IV fluids to less than 80 ml per hour unless there are ongoing fluid losses like hemorrhage.
So 75 ml per hour is the cutoff, right?
Yes.
And okay. And what else?
And ma'am, we will not limit the duration of second stage of labor in well-controlled hypertension, and we can consider cutting short the second stage with the operative delivery if there is severe hypertension which is not responding to the treatment.
Okay. And in labor in the third stage, anything you have to do?
Yes, ma'am. We have to do the active management of third stage of labor, and ergometry is.
What does that include?
Ma'am, it include giving oxytocin, IV dose of oxytocin, IV or IM dose, and control cord traction.
And
active
management of third stage of labor. You do day in and day out in during labor room. क्या होता है उसमें?
Intramuscular oxytocin 10 international units should be given, ma'am, at the delivery of the head of the anterior shoulder. Cord clamping, controlled cord traction should be done.
Stop. When do you get oxytocin in active management? It is not at the delivery of anterior shoulder.
After the delivery
Yes, ma'am. After the
delivery. Ma'am, Dr. Nupur, she said just after the delivery.
Yes, ma'am.
Just after.
Hey, ma'am. After the delivery of anterior shoulder.
Yeah, ideally it is like within a minute or so. Yeah. So what fluid? You said fluid should be 75 ml per hour. So what is the choice of fluid during labor if you need to give patient? If she's taking only, you would prefer oral fluids?
Oral fluids we will prefer if she is not taking.
If you need to give her IV fluids, then what will be the choice of fluid in a patient of preeclampsia?
Ma'am, we will prefer crystalloids, ringer lactate or normal saline.
You will give normal saline to this patient?
Ringer lactate is
preferred.
RL will be preferred, not NS. Okay. So what else? Anything to decrease her pain during labor?
Yes, ma'am. The use of epidural analgesia for women with pre-eclampsia has been proven ideal. The initial problem with this method is hypotension and diminished uterine perfusion caused by sympathetic blockade in these women with attenuated hypervolemia. Epidural blockade avoids general anesthesia, in which the stimulation of tracheal intubation may cause sudden severe hypertension. Such blood pressure increases in turn causes pulmonary edema, cerebral edema, or intracranial hemorrhage.
Okay. So you said that epidural anesthesia, you need to give her, take care of her labor pain also, so that she goes past this, has a positive birth experience and goes past the labor smoothly and without any further factors aggravating her blood pressure as well. So any indications of general anesthesia in such patients?
Yes, ma'am. The indications of general anesthesia are if there is any contraindication to the regional anesthesia, if there is fetal compromise requiring urgent delivery, pulmonary edema, hemodynamic instability, and following eclampsia.
So this is generally when the patient, you have to resort to a cesarean section in such patients. Otherwise, she was going for vaginal delivery. But in any case, if a cesarean section is indicated in emergency, then you need to give this general anesthesia. Okay. So patient has delivered and you have managed her well during her labor. So what will be the postpartum management of this patient? Preeclampsia with severe features now.
We will continue the injection magnesium sulfate 24 hours after post-delivery. We will measure the BP at least 4 times a day while the woman is inpatient. Every 1 to 2 days after up to 2 weeks, we will continue the antihypertensive treatment. Reduce the antihypertensive treatment if the blood pressure falls below 130/80 millimeters of mercury. If the woman has taken methyl dopa, then we should stop it within 2 days after the birth and change to the alternative treatment if necessary. We will review the patient after 2 weeks and 6 to 8 weeks in medicine.
So how long do you keep such patients in your hospital?
Ma'am, in our hospital, we will keep them for 4 to 5 days.
Yeah, minimum. And then after putting her on advice and if her blood pressure is controlled, and what is the target blood pressure in postpartum? Like when do you start antihypertensives in a postpartum patient?
In postpartum females, we will start the antihypertensives if the BP is above 150/100 millimeters of mercury.
Correct. And what is the drug of choice for postpartum?
The drug of choice in postpartum period is enalapril, that is ACE inhibitor, or we can prefer a second line of drugs which are amlodipine or nifedipine.
Okay. And do you repeat the investigations which you did before antenatally?
Yeah, ma'am, we will repeat the platelet count, transaminases, and serum creatinine 48 to 72 hours after birth. If these are normal, we will not repeat these results.
Correct. So your patient was severe preeclampsia at 35 plus 5 weeks. And now suppose we twist this scenario and she was severe preeclampsia at 32 plus 5 weeks only. How would you proceed? Dr. Nupur will take you further.
Okay, first of all, what will be the postpartum contraception advice which you will advise to this patient?
Yeah, the breastfeeding and the contraception advice.
Ma'am, the contraception that is preferred in these patients is intrauterine contraceptive device. Usually, contraceptives like progesterone only pills are not prescribed in these patients because as it is, there is a increased risk of cardiovascular accidents in these patients. Also, centochromane is also contraindicated in these patients. It is contraindicated till the LFTs are they come back to the normal value. When the LFTs are normal, when they come back to the normal value, we can give these patients centochromane.
And what about progesterone only pills and DMPA injection?
Ma'am, these usually progesterone only pills and MPA injections are not given because these patients are at a risk of cerebrovascular accidents or and as it is the progesterone only pills, they have a minimal risk of increase in vascular accidents. That is why they are not indicated.
Okay. Now just a question. Since you said your patient had a maternal risk factor to develop pre-eclampsia, you said no, it is the interval was more than 10 years and history of hypertension in previous pregnancy, but she reported to you at 7 months with increased BP. If she had reported to you earlier at about 10-11 weeks, what would you have done to prevent development of pre-eclampsia since this was a high risk patient?
Ma'am, if she would have come to us at 11 weeks of period of gestation with high BP, then we would have labeled her as a case of chronic hypertension.
No, she hasn't come with high BP.
Manasvi,
we maternal high risk factors.
Yeah, you told us that she already was started on a tablet at 12.
Yes, ma'am. According to the yes, ma'am.
According trying to ask what is that tablet probably according to you, and what is the evidence behind it? What do you do?
Ma'am, yes, ma'am. According to the NICE 2019 guidelines, if one major risk factor or more than one moderate risk factors are present at 12 weeks of period of gestation, we will start these patients on low dose aspirin 75 to 150 milligram OD.
Okay. And you will continue it for how much?
Till how long?
You will continue this?
Yeah. Yes, ma'am. Ma'am, it has to be continued till the delivery of the patient.
And
what is very important? Yeah.
What instructions will you give to the patient how she should take the low dose aspirin?
Ma'am, it should be taken at the hour of sleep, because it has been seen that the maximum vasospasm that is seen is at around 4 a.m. in the morning.
No,
and what is the rationale behind? Yeah.
What is the rationale to give it in night time?
Yeah.
To just to decrease the gastric irritation. It is given after food too, because aspirin is more prone for gastric irritation and all those things. And
also the studies have shown that the vasospasm occurs maximum in the morning around 4 a.m. So that's why if she gives at night, she takes it at night. So it will be taken care of. And if you've not started her with aspirin at 12 weeks, so what is the latest when you can start?
Ma'am, we can get the maximum benefits if we start aspirin before 16 weeks. But according to the ACOG 2019 guidelines, it can be given till 28 weeks.
But you need to inform the patient that the risk would be high, yes, and the benefit would be less. And yes, why the maximum benefit was till 16 weeks?
Ma'am, because trophoblastic invasion occurs in 2 steps. First occurs before 12 weeks and other occurs at 16 weeks. So giving aspirin at this time, there are maximum chances to prevent this vasospasm, and we can decrease the risk of developing pre-eclampsia in these patients.
Correct.
Okay, now, so if this patient, she developed pre-eclampsia with severe features in your case, but if she had not developed pre-eclampsia with severe features and she would have been pre-eclampsia with non-severe features, then when would you have terminated this pregnancy?
Ma'am, we would have continued the pregnancy till 37 weeks of period of gestation, and after 37 weeks we would have terminated. We would have
done a planned induction for the patient.
So what is the evidence behind it?
Ma'am, the Hypertensive trial has been. Yes, ma'am.
What does the trial says?
Ma'am, it says that if the patient of hypertensive disorder of pregnancy is induced, there will be a decrease in maternal risk factors. But in the second trial, they said that if we take the pregnancy till 37 weeks, if the BP is well controlled and if there are no signs and symptoms of severe features, then we can continue the pregnancy till 37 weeks. And it is because for maturing of the fetus and not for the maternal benefit, but for the fetal benefit.
Okay. So now supposing this patient, if she would have presented with pre-eclampsia with convulsions, how would you have managed this patient?
If this patient presents with pre-eclampsia with convulsions, the diagnosis made will be eclampsia, as any seizure episode in pregnancy, unless proven otherwise, is eclampsia, which most commonly occurs in 3rd trimester and becomes increasingly frequent when term approaches. The differential diagnosis to be kept in mind when the patient presents with seizures is epilepsy. The patient may have previous history of epilepsy or seizure disorder that should be ruled out. She may have cerebral malaria, which may be manifested along with other neurological signs and symptoms. She may have meningitis and encephalitis that can be ruled out by the presence of fever, neck stiffening, and tetanus, which is rare these days.
Yes, and okay. And so how would you manage this patient?
The aim of our management is, the first step is to let the seizure episode abort, to abort the present convulsion. Safe and timely delivery should be planned, and we have the main important thing is to prevent the recurrence of the seizures.
So what are the ABCs of yes?
The ABCs, management of eclamptic patient. Whenever the patient is having seizures, the first thing we have to do is let the seizure episode subside. We should avoid injury to the patient by providing padded bedside rails and physical restraint. Oxygenation should be maintained. Breathing should be maintained for the mother and the fetus. Oxygen should be started at 8 to 10 liters per minute by face mask. Oxygen saturation should be monitored by pulse oximetry, and arterial blood gas measurement should be done. We have to minimize the aspiration by giving left lateral decubitus position to the patient. Suctioning and of the vomitor should be done, and chest X-ray after the cessation of the convulsions to rule out any aspiration. We have to we have to secure the IV line, blood sample should be taken, blood should be arranged, Maxel should be given.
The most important thing is that before you do any catheterization or invasion, like you take in samples, you have to give Maxel first,
Magnesium
so that
sulfate.
the
Yes, ma'am.
patient's irritability and everything is taken care of. Only after that you will draw the sample, right?
What will you do first? You will give first antihypertensives or you will give anticonvulsants first?
Yeah, very important.
Too dangerous.
You should know.
First step, ma'am, we'll give her magnesium sulfate along with.
You always give antihypertensives first because hypertension, severe hypertension, it is more dangerous. It can cause intraventricular hemorrhage. While the Maxel, it will only prevent recurrent seizures. If the patient has already come with seizure, it will not have any effect on the current seizures because the seizures of eclampsia, they are normally self-limiting, generalized tonic-clonic seizures. And okay, then
Yes,
what we will do?
We'll immediately plan the delivery of this patient. But if the convulsions recur, we can repeat the dose of magnesium sulfate 2 to 4 gram IV over 5 minutes. If these seizures persist for 20 minutes after the bolus or more than 2 recurrences, it means it's refractory to Maxef and we have to think about other anticonvulsant drugs. The drugs that can be used are lorazepam, diazepam, and phenytoin. Head imaging should be considered in cases of recurrent seizures that are refractory to magnesium sulfate.
Nowadays, we even use injection levetiracetam.
Levetiracetam is used, yes, ma'am.
Is also used for in case the patient does not respond to Maxel. So, what are the contraindications in which you will not give Maxels?
Magnesium sulfate is contraindicated in patients who have hypocalcemia, myasthenia gravis, who have cardiac abnormalities like cardiac block, myocardial ischemia, cardiac failure. In these cases, magnesium sulfate is contraindicated. Those with moderate to severe renal diseases, magnesium sulfate is contraindicated.
Okay. Now, since you have said that in these patients which are refractory to Maxel, we will go for head imaging. So yes, what is the role of imaging in the patient of eclampsia?
In the patients of eclampsia, the imaging shows abnormalities like cerebral edema. We can look for posterior reversible encephalopathy syndrome can be identified by imagings like CT or MRI.
What do you see in press? What are the findings, MRI findings?
Ma'am, in the posterior lobe, that is the occipital region, there will be
vasogenic edema.
There will be bilateral vasogenic edema. It will be present in the occipit plus the biparietal lobe. And there will be hyperintensity shadows on T2 imaging. And what is the other condition by which we can see now besides press? Do you know any other?
What are the findings?
Ma'am, other than press, if the patient is having recurrent seizures, she can also develop cerebrovascular, she can develop stroke. Because of hypertension, she can have thrombotic stroke.
What is that condition called? What is that condition called?
It is reversible cerebral.
Posterior reversible constrictive syndrome, in which there is thunderclap.
Thunderclap is the worst headache of her lifetime she will have at that time. So that way you can differentiate.
Okay. So, for the termination, it is the same as we go for a patient with severe pre-eclampsia. So we need not to discuss that because we have already discussed. So what is the role of status? What is status eclampticus?
Status eclampticus, persistence of the seizures for 20 minutes even after magnesium sulfate, or recurrent seizures that are not controlled by by Maxelf. It is labeled as status eclampticus.
And how do you manage?
The anesthetic help patient ventilation should be achieved by intubation of the patient, and anesthetist and physician should be consulted for
deep sedation, muscle relaxant, and intubation.
Yes, sodium. Yes, ma'am.
For the management of status epilepticus.
Yes, ma'am.
Okay. So, yes, and what about the postpartum care? If the patient, is it always necessary that the patient of pre-eclampsia, eclampsia will be preceded by pre-eclampsia, or it can present even without proteinuria and hypertension.
The patient without proteinuria and hypertension can also present in the postpartum period with a seizure episode.
What is the percentage of postpartum
15% of the patients will present without hypertension and
So
protein.
in postpartum period, also in a patient of pre-eclampsia, we should always ask for warning signs.
Yes, ma'am.
Which we forget to mention in the postpartum care of the patient of your case. We should always ask about warning signs because there is always increased chances of postpartum eclampsia also in the postpartum period.
Yes,
Now coming to the another dreaded complication, what is HELP?
Ma'am, HELP syndrome is the microangiopathic hemolytic anemia, which is characterized by hemolysis, elevated liver enzymes, and low platelet count. In 85% of patients, the HELP syndrome will be accompanied by high blood pressure and proteinuria, but in about 10 to 15% patients, there will be no evidence of high blood pressure or proteinuria. It usually presents in the third trimester between 28 to 37 weeks of period of gestation. And for diagnosis of HELP syndrome, we use
in postpartum period also.
Yes, ma'am. It can present in antenatal, intrapartum, postpartum. Yes, ma'am.
So what is complete, incomplete, and what is Mississippi classification? You would tell about.
Ma'am, for diagnosis of HELP, we consider the Tennessee's classification. Ma'am, there are three components to it. First of all, we will see for hemolysis, and any of the two should be present. That is, the serum bilirubin should be more than 1.2. There should be evidence of hemolysis on a peripheral smear. The lactate dehydrogenase levels should be more than 600, and haptoglobin levels should be less than 25 milligram per deciliter. There should be abnormal liver function test, that is the AST and the ALT should be more than or equal to 70 international units, or they should be twice the baseline. And the third component is the low platelet count, which is defined as a platelet count of less than 1 lakh. Any of the two should be present to classify the patient as HELP syndrome. There is also another classification, the Mississippi classification, which basically classifies the HELP syndrome based on the severity of the disease. So class 1 is when the platelet count is less than 50,000, LDH is more than 600, and AST and ALT are more than 70 international units. Class 2 is when platelet count is between 50,000 to 1 lakh, and LDH is more than 600, AST and ALT are more than 70 international units. And class 3 is the mildest form, in which the platelet count will be more than 1 lakh, the LDH will be more than 600, AST and ALT will be more than 40 international units.
Okay. How would be the patient of HELP syndrome presents to us? What will be her main symptoms?
Ma'am, most of these patients, about 85% of patients, they will present to us with high BP records and proteinuria. The most common clinical feature that is seen in these patients is epigastric pain. Other than that, there can be history of nausea and vomiting. There can be history of decreased urine output, and they basically present to us similar to patients of severe pre-eclampsia.
Basically with right upper quadrant pain, nausea, vomiting, malaise, so in a patient who presents with these symptoms, what are the other differentials besides HELP syndrome which we should always keep in mind?
Yes, ma'am. The other differential diagnosis of HELP syndrome is acute fatty liver of pregnancy, which also presents at in the third trimester. But in acute fatty liver of pregnancy, it will be accompanied with hypoglycemia, and the DIC will be of a more severe form. Ma'am, other diagnosis is thrombotic thrombocytopenic purpura, but TTP usually presents in early part of the pregnancy, that is the first trimester and the second trimester. And in TTP, we will see on peripheral smear that there will be a more severe hemolytic anemia as compared to HELP syndrome. Ma'am, other diagnosis is hemolytic uremic syndrome, which is a rare entity where the LFTs will be normal, but there is severe renal dysfunction. So kidney function tests are deranged in this in these patients.
And it mostly presents in postpartum period.
Postpartum period, yes, ma'am. Ma'am, other diagnosis is antiphospholipid syndrome, where the patient will give us history of recurrent pregnancy loss, any history of vascular accidents, and in these patients, when we'll do the investigation, antibodies, lupus anticoagulant antibodies will be positive, beta-2 glycoprotein antibodies will be positive.
Okay, so how would you manage this patient? What are the investigations which you would like per se related to health? Baki to all will be same as per the for severe pre-eclampsia with severe features. Per se for health, what will be the other investigations which you would like to do?
Ma'am, I will, apart from the baseline investigations that we are doing in severe pre-eclampsia, I will also like to do a DIC profile in which I will do fibrinogen levels and D-dimer levels.
And is there any role of peripheral smear in these patients to look for?
Yes, ma'am. Since it is a microangiopathic hemolytic anemia, peripheral smear is most important for making the diagnosis of peripheral smear. We will see on peripheral smear, we will see evidence of hemolysis in the form of schistocytes and helmet cells.
Helmet cells, blood cells, these all can be seen in per smear examination. Now,
Yes,
so now how would you, what is the definitive management for health?
Ma'am, we have to remember that there is no role of expectant management in HELLP syndrome. So in HELLP, if the patient has been diagnosed with HELLP syndrome, we will first administer the anti-seizure prophylaxis, and if the BP is high, then we will also administer antihypertensives. We will see the gestational age of the patient. If the gestational age is more than 34 weeks of period of gestation, we are simply going to deliver the patient. If the gestational age is less than 34 weeks, we will only consider the patient for corticosteroid cover for 48 hours. And then irrespective of period of gestation, after the corticosteroid cover, we are going to terminate the patient. And this corticosteroid,
even we can give one shot of corticosteroids and we can deliver
and
the
then
patient, because it has been shown in evidence that one dose of corticosteroids also causes significant reduction in respiratory distress. So we in patients we don't need to wait for another 48 hours if the patient, because the whatever the expected management we do, it is only for the neonatal fetal well-being, and it is at the risk of maternal outcome.
Yes, ma'am.
So we should always weigh this.
Yes, ma'am. Ma'am, if the period of gestation is less than 34 weeks and if there are signs and symptoms of maternal deterioration, like there is abruption or there is evidence of pulmonary edema, eclampsia, if there is evidence of stroke or hepatic bleeding, if the fetal heart rate is non-reassuring, or there is intrauterine death, then we will simply terminate the pregnancy after maternal stabilization.
Okay. So how would you terminate?
Ma'am, there is no, it has been seen that vaginal delivery is better than cesarean section. So we will only go for cesarean section for obstetric indication, or if the patient is rapidly deteriorating and we need emergent termination.
Cesarean section. What is the choice of anesthesia in a patient, since she is a patient of HELLP with reduced, the platelets will be less. So what is the choice of anesthesia in these patients?
Yes, ma'am. Since in HELLP syndrome there is thrombocytopenia and the patient can be in DIC also, so the coagulation profile will also be deranged. Usually the general anesthesia is not preferred. The regional anesthesia is not preferred, and we will prefer general anesthesia over regional anesthesia.
And would you like to go for correction? Would you like to go for correction of the platelet count also before?
Yes, ma'am.
We always correct blood, FFP, and platelet in these patients.
Yes, ma'am. If the patient,
what is your target platelet count for vaginal delivery and for cesarean section?
Ma'am, for cesarean delivery, at least 50,000 platelet count has to be
70,000 platelet count for cesarean delivery and 50,000 for vaginal delivery.
If it is more than 70,000, then only you can proceed for cesarean section.
Yeah, so 75 is for cesarean and 50 is for vaginal, right?
Okay. And so what? So how will you monitor this patient in the postpartum period?
Ma'am, I'm going to repeat her complete blood count, the liver function test, the coagulation profile, and the kidney function tests after 48 to 72 hours. And ma'am, the blood after delivery of the patient, the blood pressure monitoring of the patient is to be continued. At least 4 times a day the BP has to be monitored, and if the blood pressure is more than 150 by 100 millimeters of mercury, then I'm also going to institute some kind of antihypertensive for the patient. And the target blood pressure that has to be kept during the postpartum period is 130 by 80 millimeters of mercury.
It has been said that in a patient of HELP, normally the platelet counts return to their normal value, and
Yes,
LFT comes down by second postpartum day. But if after 4th postpartum day, the platelets are still decreasing and LFT is still increasing, then we should always validate our initial diagnosis of HELP.
Yes,
therefore, frequent lab investigations is necessary for a patient of HELP, because HELP, it is a laboratory diagnosis.
Yes, ma'am.
So you need frequent lab investigations for a patient of HELP. So what is the risk of recurrence of HELP in next pregnancy?
Ma'am, there is a 50% risk of recurrence in
about 19 to 27% risk of HELP next pregnancy.
It's up to 30%, yeah.
And it is more in cases of class 1 type of, which is severe type of HELP syndrome. Okay. So
what is the recurrence of pre-eclampsia with severe features or pre-eclampsia without severe features in next pregnancy? At the same time, you should know this also.
– 8 to 10%.
What is the normal risk? What is the normal incidence of pre-eclampsia?
8.3% in our Asian population.
And what is in India? What is in India?
Ma'am, about 7%, 7 to 8%.
India, it goes up to 10%, and the risk goes up to 16% of preeclampsia with severe features. Okay, 16% tak jata hai. And what about eclampsia? A patient who had antepartum or intrapartum eclampsia in past pregnancy. So, what is the risk of recurrence in this pregnancy? ज़्यादा होगा कि कम होगा?
It is also roughly about 25
to 40% तक जा सकता है बस इसमें 30 की जगह हेल्प जैसे 30 तक है इसमें 25 to 40% है. So it's very important to take the history of कि last time क्या था, seizures था, antihypertensives थे, IV management था या oral management था, वो important है. And now suppose this patient,
Now if there is a third scenario, now if a patient who is a known case of chronic hypertension, है ना, she comes to you, now she is going to plan for a pregnancy. So what is the preconceptional counseling that you will advise to this patient?
Ma'am, if the patient who is coming to us, who's a known case of hypertension, known case of hypertension, if she is coming to us in pre-pregnancy period, first of all, I'm going to advise, we will target on the modifiable risk factors of the patient. First of all, I'm going to advise if the patient is obese or overweight, I'm going to advise her to reduce the weight. A BMI of less than 25 is the cutoff, and I'm also going to advise her the DASH diet, which is dietary approach to stop hypertension, in which I'm going to tell her that she should take salt intake of less than 5 gram per day, sodium intake of less than 2.4 gram per day, and I'm going to tell her for she should do more physical exercise at least 3 to 4 times per week. If there are any
Manasvi, how do you explain the patient this DASH diet? How will she calculate ki kitna salt khana hai?
Ma'am, she should take a pinch of salt in one day.
A pinch of salt is 5 grams.
No additional salt should be added to her diet.
No additional salts, that is sauces, preserved foods, they should be avoided. Ketchups, right? Pickles, they should be avoided. And she should use minimum of salt in all her dishes. And that means total in a day, she can take one teaspoon of salt, right? Yeah.
Ma'am, other than that, I am going to tell her to take more of vegetables and fruits. If there are any other addictions like smoking, she should quit them. And if she's on any antihypertensive drugs like ACE inhibitors or ARBs, we should take a medical opinion to review these antihypertensive drugs. And with that, I'm also going to start prophylactic folic acid for the patient.
Okay. Now, supposing because of some reason she could not come to you during the preconceptional time, and she reported you when she's 8 weeks pregnant. Now, how would you manage at 8 weeks?
Ma'am, if in a patient of chronic hypertension, complete workup has to be done. So we will first monitor her BP. We will advise for complete blood count with platelet count. We have to get the liver functions and the kidney function tests done. We have to do the spot urine creatinine ratio. Ma'am, in these patients especially, we have to get urine culture sensitivity and urine RM done, because in urine routine and microscopy, casts can be seen in patients who have chronic renal diseases, and urine culture is done to rule out any infection which are also a cause of proteinuria in these patients. Ma'am, I will advise her for an ECG. If the ECG is abnormal, then I'm going to advise for an echocardiogram. ECG is usually abnormal in cardiac cases of secondary hypertension, like coarctation of aorta. Other than that, I'm going to advise her a fundus examination. Ma'am, in these patients, we have to also get urine ultrasound, renal ultrasound done to rule out any renal disorders like renal artery stenosis. Ma'am, we have to take detailed history of these patients, and if the patient is telling us that with high BP, she has a history of tremors, palpitations, we have to get her urine metanephrin done to rule out pheochromocytoma.
Yes, besides this, you will switch over from, if the patient is taking ACE and ARBs and thiazides, so you will switch over to labetalol or whichever drug we want. And plus, since the patient is a known case of chronic hypertension, at 12 weeks, we will recommend low dose calcium. If the patient is having low calcium, then we will recommend 1 to 1.5 gram of calcium per day. For prevention of pre-eclampsia.
Yes,
so can we start with Dr. Nupur? Can we answer the questions first before going further, because time is now getting short?
Ma'am. Yes, ma'am.
Actually, I just scrolled through the questions, so most of them they are covered, barring one or two. The most common question which is being asked is that any role of intercurrent MAC-self? Yes. So what is intercurrent MAC-self and any role of that nowadays?
Ma'am, intercurrent MAC-self is basically given in patients who are their period of gestation is less than 34 weeks. So, ma'am, we just give the intercurrent MAC-self just to cover the corticosteroid cover, give the corticosteroid cover. But presently, because the patient's condition can, yes, ma'am, patient
can anytime worsen and
deteriorate. Yes, ma'am, that is right.
Who is a candidate for MAC-self is certainly not a candidate for expectant management nowadays.
Yes,
you don't need to prolong the pregnancy. You have to terminate the pregnancy. So there is no role of intercurrent MAC-self. Another question which is coming very frequently is being asked is that we were going to that thing only. So suppose this patient, you knew her history, and if you don't know the history, so what is the prenatal screening or what are the predictors of preeclampsia in a patient? What are the predictors as per you? So how can you predict the occurrence of preeclampsia in a patient who gives or doesn't give any history of hypertension in her last obstetric history?
Ma'am, if the aim of prenatal screening is to detect the preterm preeclampsia in the patients with high risk, so we have done various biophysical and biochemical markers to detect the which are predictors. The predictors are mean arterial pressure, uterine artery pulsatility index, serum pregnancy associated plasma protein A, serum placental growth factor, SFLT 1:2 placental growth factor ratio. These are various predictors which can be used.
Ma'am, the biophysical markers are mean arterial pressure and uterine artery pulsatility index. Usually, in the first trimester of pregnancy, at around 5 weeks of period of gestation, the blood pressure, the mean arterial pressure decreases in these patients because of action of progesterone and prostaglandins. They have a vasodilatory action. The MAP continues to decrease in the second trimester as well, but after 28 weeks, the MAP increases to a normal value in third trimester. So if the patient is at a higher risk of developing pre-eclampsia in further course of her pregnancy, the mean arterial pressure will be high in these patients. So as the so will be the uterine artery pulsatility index, which will be high in patients who are at a higher risk of developing a pre-eclampsia in further course of her pregnancy. Ma'am, there are biochemical markers also. Ma'am, there are in pre-eclampsia, there are some anti-angiogenic factors and angiogenic factors that play a role. So the angiogenic factors are placental growth factor, vascular endothelium growth factor, and the anti-angiogenic factors are the soluble FMS like tyrosine kinase or the soluble endoglin. So in pre-eclampsia, the levels of these, there is an imbalance, and the soluble in the anti-angiogenic factors, they increase in pre-eclampsia. So we can calculate individually, we can calculate the values of these markers, but it has been seen that as an individual factor,
they are not that much
not
efficient
as
to
much.
predict the preterm
Alone
pre-eclampsia.
they cannot predict pre-eclampsia as much as they can use in a model or a combined.
Yes, ma'am.
And another question which is resurfacing is that we had already talked about low dose aspirin. Dr. Nupur has also detailed, and you people have also corroborated the same. But another thing is there any role of calcium supplementation in patients to prevent pre-eclampsia?
Yes.
So that question is being popped up in the chat box.
They had said 1 to 1.5 gram of calcium in a patient who are having
hypocalcemic. But one thing I would like to add is that because it is seen that in general population, because calcium supplementation will definitely help getting a good prognosis and a good maternal and maternal outcome. So it is said that during the COVID-19 pandemic, calcium supplementation should be given to prevent hypertensive disorders and the morbidity and the mortality associated with it. And what are the ineffective interventions which you know of? All the postgraduates must know. They should only say that the only evidence goes for low dose aspirin and calcium supplementation in cases of hypocalcemia, and otherwise rest all the interventions to prevent pre-eclampsia are
ineffective. There is no evidence studies suggesting.
That includes vitamin C, vitamin
C, antioxidants.
Yeah. And last question I would like to ask is, what are the long-term risks in a woman who had an hypertensive disease of pregnancy? Because it is very important. What are the long-term risks?
How would you counsel her that what she will have in future? What future holds for her?
The long-term consequences of the woman with pre-eclampsia, she may develop cardiovascular disorders, like she may have chronic hypertension, she may develop ischemic heart disease, atherosclerosis, coronary artery calcification, cardiomyopathy, thromboembolism. She may have neurovascular accidents like stroke, retinal detachment, diabetic retinopathy, metabolic disorders like there are high chances of development of type 2 diabetes, metabolic syndrome, dyslipidemia, obesity, renal abnormalities like glomerular dysfunction, proteinuria, and CNS dysfunction like white matter lesions, cognitive dysfunction, and retinopathy.
Okay. So what advice will you give to these patients?
Ma'am, we will advise them lifestyle modifications, dietary modifications. We will advise them to be to do more physical activities and follow up more regularly and frequently in the medicine OP.
Ma'am, we have to tell her that she has to get her blood pressure checked annually, and other target organ investigations are to be done every 4 hours, 3 to 4 hours.
And to prevent development of obesity, she should what she should do?
She should exercise regularly.
Ma'am, she has
Maintain her
7 days
BMI
a
less
week.
than
Correct.
25.
So BMI targets should be told to her, right? Okay.
I think we are done.
Yes, ma'am.
Thank you.
I'll just check if any other questions are left.
There's one Q&A section initially. Why was Levetiracetam started? What is the normal cutoff to start antihypertensive? And why only 800 milligram of Levit was given when maximum dose is 2400? Why did we switch to other drugs so early, and any benefit of that? So this is what you have to answer.
Ma'am, according to the NICE 2019 guideline, which they have adapted from the CHIPS guideline, that we have to control the BP. There should be a tight control of blood pressure. So the target that we have to maintain is 135 by 85 millimeters of mercury. So that is why in our patient at 140 by 90 millimeters of mercury, we had started her on antihypertensive. Again, ma'am, the maximum dose that we gave to the patient was just 800 because of the phenomena of tachyphylaxis, because it has been seen that if any drug, if it is given at a maximum dose, the receptors get saturated, and the required action of the drug is not we don't get the required action of the drug by giving her the maximum dose. That is why the maximum dose at Safdarjung is tab lobetalol 800 milligram per day.
So if a patient does not, patient blood pressure is not controlled by 800, that is 200 milligram QID, there will be no benefit attained if we increase the dose further. We should rather decrease the loss of time, and we should start on the other antihypertensive. Another question which I'm seeing in the chat is that we have talked about the long-term consequences in mother. Any long-term consequences of pre-eclampsia or hypertensive disorders of pregnancy in the offspring?
Ma'am, yes, ma'am. The baby can in future the baby can develop metabolic syndrome. There can be
increased risk of hypertension in the baby also. Baby can also develop. There can be developmental delay also in the baby.
Ma'am, it has been seen that these babies are
autism spectrum disorder that has also been shown to be there in the offsprings of such mothers. Okay. So any test, one more question is, there any test you can do is to differentiate between severe preeclampsia and features of COVID in pregnancy? Very easy. You've already talked about it. You've already talked about it. Any test to do, any ratio?
Ma'am, the soluble FMS like tyrosine kinase
placebo growth factor ratio.
So that cutoff is there for differentiating between COVID-19 and severe preeclampsia, because we've seen that COVID is worsened in patients with severe preeclampsia. Okay. And another question is,
most of them have been answered along with our other experts.
Any role of heparin in eclampsia, that is also given. So there is no role.
There is
no role. And what is the risk of onset of HELP in the postpartum period? Risk of onset of HELP in the postpartum period. Dr. Nupur had already highlighted the fact that HELP can occur at any time. It can occur antepartum, intrapartum, and again it can occur postpartum also. So what is the risk? It is 1/3. Yeah, 1/3 of the population. So 30% of the patients, they can have they can develop HELP in the postpartum period. So you need to be vigilant, and therefore we always within 48 hours after delivery, we get these investigations done in such patients. Okay. Yes, ma'am, I think we've taken up all the questions.
Yeah, thank you. And other differential diagnoses have been answered by Dr. Josna Suri in the chat box itself. So you can also read it up, all of you. It was excellent discussion done by all the three PGs, Kajal, Manasri, and Monica, and very well moderated by Sheeba and Nupur. Thank you very much. And thank you, Dr. Anjali, for staying till the end and chairing the session. I would also like to thank the AOGD team. Of course, they couldn't come today because of that unfortunate incident. But yes, that platform is on the AOGD only. And our academic partners, Dr. And Jagsonpal, Dr. Deepika and Mr. Dogra, they have always helped us in this forum. And of course, the excellent questions and answers both by our audience, that was really very well done. Thanks for all that. So thank you very much, all of you.
And
So
thank
next,
you,
Thank you. Thank you.
PG was also very excellent. They answered almost every question. They had prepared very well.
yeah, they did
Very
very
well done.
of course.
All three of you have read it very well. And it was a really good presentation. And thank you, Dr. Malik ma'am and Dr. Shivani ma'am, to give us this opportunity.
Dr.
to-
Shivani had to leave in between because she was on call and she just had to go.
Okay, ma'am. Okay.
Okay, thank you, ma'am.
And thank you, Dr. Nupur,
Thank you,
for
ma'am.
coordination. Thank you so much. Thank you.
Okay, ma'am.
Thank you.